Good evening, everyone. I'll be talking today upon clinical practice guidelines for the prevention and management of radiation dermatitis. So, moving on to generally what we see is so let us first just quickly revise through the anatomy of the skin. So, what we see, skin is made up of three layers, which is hypodermis, dermis, and epidermis. Hypodermis is what is made up of fat and connective tissue. Dermis is what we see, the sweat glands, the sebaceous glands, connective tissue, fat, blood vessels, and the epidermis is the outermost layer, which is a protective layer, and it is made up of five cell layers, which is stratum basal, the stratum spinosum, which has Langerhans cells, your Merkel cells, and living keratinocytes, above which it is stratum granulosum, lucidum, and corneum. And corneum is what which has the dead keratinocyte layers. Radiation dermatitis is defined as a cutaneous inflammatory response to biologically effective levels of ionizing radiation. And radiation dermatitis is seen generally in 95% of the uh, patients who receive radiation. Now, radiation is one of the most common form of treatments or therapies which any cancer patient has to undergo in most of these cases. Next slide, please. Yeah. So if you go at the mechanism of action, what we see, why does the radiation dermatitis occur? So basically, ionizing radiation incites a signaling pathway between the epidermis and the dermis. And the hallmark for radiation-induced skin injury is the transendothelial migration of leukocytes and the immune cells from circulation to the irradiated skin. And all these keratinocyte, Langerhans cells, fibroblast cells, endothelial cells stimulate this immune response and causes production of cytokines, chemokines, endothelial cells to produce different adherent molecules. And that is when we see the radiation dermatitis. So acute radiation dermatitis or the acute radiation skin toxicity is because of the various cytokines and chemokines and the interleukins which bring about the response. Whereas in chronic radiation dermatitis, it is more of the fibroblast which does more of the play. Now, there are various enzymes which have been thought to be involved in the process of radiation injury, and it is mostly because of the imbalance which is caused by the antioxidant and the redox control over wound healing. It is also said that the T helper type 2 mediated immune response is responsible for the non-resolution of the inflammatory response and the delay in wound healing. So, moving on to what is acute, there are two types of radiation dermatitis, that is acute and chronic radiation dermatitis. Now, acute radiation dermatitis is what is seen within 90 days following radiation. Can we move to the next slide, please? So that is within 90 days of radiation. It is generally what we see, the features, what we see is the immediate structural tissue damage. There is generation of short-lived free radicals, which causes damage to the mitochondrial and the nuclear DNA and resulting in inflammation. So there is destruction of the basal keratinocytes, and because of the multiple repeated exposure to radiation, the cells do not repopulate and replenish the epidermal layer. So what we generally see the features, we see what is the faint or the mild erythema, which occurs within hours of radiation, and it is basically because of the capillary dilatation. Sustained hyperpigmentation or erythema occurs until 2 to 4 weeks. As the erythema develops, it is associated with edema, pruritus, and tenderness. Then comes the dry desquamation, which is generally 3 to 6 weeks of RT. And above 40 gray, what we see is the moist desquamation, wherein there is serous exudate, there's tenderness, redness, hemorrhaging crusting, and the potential for development of bulling. Now, as there is a breakdown of the skin barrier, it is causes pain and is increased susceptibility to contact injury. Generally, the time taken for resolution is 2 to 4 weeks following the end of the treatment. And as the epidermal keratinocytes repopulate, the immune response cascade reverses. There is resolution of the symptoms for acute dermatitis. Now, in contrast to this, if we look at the chronic radiation dermatitis, it is generally seen more than 90 days following radiation. And it is basically because of the dysregulation between the pro-inflammatory and the pro-fibrotic cytokines. So there is sustained loss of the skin appendages, that is the sebaceous gland, hair follicles, hair follicles, and different changes in the skin. There is hyperkeratosis, parakeratosis. There is telangiectasia of the blood vessel due to the blood vessel dilatation, and damage to the blood vessels causes tissue hypoxia and the development of skin ulcers. Because of this, there is dense fibrosis, elastosis, and delayed tissue healing. And it generally takes about months to years for the resolution, and it does lead to a poor quality of life. If you look at the dose-wise distribution, what we've just said, that is in chronic radiation dermatitis, all the effects are generally seen if the doses are more than 45 gray. It is seen months to years later, and the different aspects is delayed ulceration, dermal necrosis, fibrosis, and telangiectasia are the features of chronic radiation dermatitis. If you see at the acute radiation dermatitis, erythema, hyperpigmentation generally seen within hours of radiation, up to 2 weeks, 2 to 20 gray of radiation doses. Appellation is seen at around 6 to 10 gray, again at the end of first week and second week. Dry desquamation is generally seen 20 to 30 gray, which is again 3 to 4 weeks. Moist desquamation is seen at 30 to 40 gray, which is in the fourth week of radiation. And ulceration is generally seen above 40 gray of radiation, which occurs in the fifth week of radiation, 5 to 6 weeks. So moving on to different grading criteria, there are multiple grading systems which are used for grading the severity and of radiation dermatitis. What we most commonly use are the RTOG ORTC guidelines and the CTC NCI CTC grading system. So the CTC and the CTC and the RTOG guidelines are more or less similar. So grade 1 acute radiation dermatitis is just faint or dull erythema. There's dry desquamation, there's epilation. Grade 2 is bright erythema, which with patchy moist desquamation or moist desquamation in the folds area, skin fold area. And grade 3 is confluent moist desquamation in areas other than the skin folds. And grade 4 is ulceration. Similarly, in chronic radiation dermatitis, what we look at the skin and the subcutaneous tissue as well. So the skin atrophy, which is mild, moderate, marked, and ulceration as grade 1, grade 2, grade 3. So just giving in CTC is again the same, which is almost the same. There is grade 1, 2, 3, and 4, and grade 5 is what they have is dead. Now, if we look at the features, again, if you see the pictures, grade 1, we see there's erythema, dull erythema. Grade 2, you see bright erythema. You see some areas of moist desquamation. In grade 3, which is a picture down below, you see it is a complete patch of mucositis. And grade 4, you can see that there is a bleeding present at a few areas. If you look at the factors which affect radiation dermatitis, there are patient-related, there are disease-related, and there's treatment-related. So patient-related is generally elderly age group, smoking, diabetes, obesity, multiple underlying connective tissue disorders, if they have microcirculatory impairment or poor nutritional status, immunocompromised status. Disease related means the site of the disease or the type of disease which requires a particular amount of radiation dose for treatment. Treatment related, there is the dosing, the schedule of radiation, whether use KV radiation or the use of bolus or larger radiated volume or concurrent chemotherapy, or in cases of overlapping fields. So now that we know what is radiation dermatitis, what causes radiation dermatitis, what are the features and what are the factors affecting, what is the general, you can say, not the guidelines per se, but what is generally followed in the practice. So yes, now that we have moved from cobalt to linear accelerators with skin sparing effect, we can definitely decrease the doses of radiation. The modern radiation therapy techniques, hypofractionated radiation, wherein we give a higher dose in a small duration of time. So generally, the skin reactions are seen after completion of treatment, and they do not disrupt or cause interruptions during radiation treatment. Generally, general skincare, which we generally follow during the treatment so as to avoid severity of radiation dermatitis. You keep the area dry, irradiated. You can clean with water and mild soap. You can use moisturizers, avoid skin irritants, wear loose fitting clothes, avoid powder in skin fold area, avoid skin exposure, and avoid shaving. This is what is the general, you can see, instructions which we do tell all our patients. Now, please keep in mind the specific points which I've highlighted in red. We also use multiple skin moisturizers, topical steroids, even non-steroidal creams such as trolamine sometimes, or protective dressings, and we see to it that there is no secondary infections. So if we go on to management, what we generally use are the topical applications of moisturizers, aloe vera, gentian violet, corticosteroids, specifically mometasone and betamethasone, creams and dressing, which is hyaluronic based compounds, sucralfate. In Tata, we do use human amniotic membrane, uh, multiple hydrocolloid and occlusive hydrogel dressings, use of topical antimicrobial silver sulfadiazine based dressings for infective lesions, and for chronic radiation dermatitis, the non healing ulcers, hyperbaric oxygen therapy, and surgical management, which is generous debridement, and maybe the use of scalp and grade 4 non healing ulcers. So, if you have to give, I have to give a general brief overview. What is generally followed is for grade 1, that is the faint erythema, we cleansing, moisturizing, use of topical steroids once or twice daily, which is continuous post 2 weeks post radiation. For grade 2, grade 3 is the main idea is to prevent secondary skin infections and therefore to use barrier dressings. In grade 4, which is the full thickness, the first thing is to interrupt the radiation treatment, to review the treatment plan as to why exactly the patient is having grade 4 radiation dermatitis, and to treat accordingly if there's any risk of infection. So when now that we have seen all these different instructions or different treatment protocols which we follow, most of these are there's not a definite consensus. There are a lot of trials which have said for and against or for most of the points which I have just discussed. So keeping this in mind, there was a study by international interdisciplinary experts who tried to develop a treatment and a consensus based guideline for this. So of all the things which I've just mentioned, I'll specifically highlight those which were definitely agreed upon by the expert panel, and there are comments for the same. So washing with water or mild soap, with or without mild soap, yes. So there was definite agreement with the panel that yes, we could do that. There was a lot of concern that as to uh, um, wetting the area with water can result in increase in severity, or compared to keeping the area dry. So it was said that it was seen that there was significant reduction in itching, erythema, and desquamation when compared to no washing. Use of topical moisturizer, again there was a lot of confusion regarding whether it can be used before radiation or it cannot be used before radiation. So the experts, as per the research, have suggested that yes, you can go ahead, use moisturizing creams, gels, and the concern which is basically for the bolus effect. So they said there is no bolus effect for less than 3 layer, only for very thick layers of gel application. If it is more than 3 then there is some amount of bolus effect which is seen. Again, use of antiperspirants during radiation treatment or deodorants. So there were concerns about alcohol-based deodorants, which causes deposition of alcohol, probable bolus effect. But it was seen that non-aluminium based deodorants can be definitely used, and yes, of course, it does help in less sweating. With use of topical corticosteroids, so multiple studies have shown mometasone and betamethasone reduces discomfort and itching, and it is definitely recommended. Now, for grade 2, grade 3, a lot of hydrogel based dressings or non steroidal based dressings, hyaluronic acid based dressings were used. So, there was the panel suggested that there is no or very limited evidence for this, and it is not recommended. For chronic radiation dermatitis, use of pentoxifylline and vitamin E, and for telangiectasia and fibrosis, dye laser can be used, was recommended. So there was this recent paper which was published. I have not gone through the entire paper. I could come across only the abstract. So I'm just going to present the key points which are mentioned over there. So this was for chronic radiation dermatitis and for radiation fibrosis. It was just recently published, and so it was, again, there was a multidisciplinary panel of 27 providers, out of which 25 were physician and 2 were nurses. Of the 25 physician, 19 were dermatologists, 2 were radiation oncologists, and 4 were other oncologists. Now, what they did was they, depending on the different aspects of radiation, chronic radiation dermatitis, what are the factors, what is should be the treatment like? There were multiple questions which were asked, and they underwent two surveys. If there was a strong consensus, that is more than 70% of the participants strongly agreed, it was a yes recommendation. If it was 50 to 69%, that is moderate consensus, it went to the second survey round of second survey. And if the statements, or if there was less than 50% agreement, then it was strongly disagreed by the panel. So this is the last slide. I'm sorry for the very busy slide. So what they looked at is whether the use of topical steroids can be used. And 93% in the first survey itself said that yes, topical steroids can be used for treatment of acute radiation dermatitis. Now, with respect to factors which cause chronic radiation dermatitis, whether radiation doses, re-radiation, the volume, the anatomical location does impact the severity of chronic radiation dermatitis. So most of the panel, the experts agreed that yes, it does. For connective tissue disorders in smoking, there was a moderate disagreement in the first survey, but in the second survey, they did agree that this does have an effect on the severity. Regarding the different clinical presentation and morphological, the entire panel agreed that chronic radiation dermatitis, the features which are seen is telangiectasia, skin fibrosis, dermal atrophy, contractures, epidermal atrophy, hypo and hyperpigmentation. For prophylactic treatment of chronic radiation dermatitis, most of the panels in the second survey agreed that sunscreen application after radiation does protect the skin from UV radiation, UV light, and that's why it must be used. And laser therapies to be used for who have the experience in using laser therapies for the treatment of telangiectasia and fibrosis in chronic radiation dermatitis. Most of the panel agreed that chronic radiation dermatitis does have a negative impact on quality of life. So we've seen that there are a lot of things in practice what we do, and there is a very limited data or very contrasting data for the treatment of radiation dermatitis. So the Delphi consensus has tried to throw in some light wherein which could be followed in general, and which have no basis for disagreement. Thank you.